first I want to do a demo on the lower. So basically, I'll walk you guys through step by step on how I typically approach the lower arches in our practice. The first thing that we always want to do in our preparation is have a good CBCT so that we can understand what our ridge thickness is in this case. And then also we want to have a nice flat ridge. This model already has a nice flat ridge for the most part. But usually in practice, you may have to do some alveoplasty, especially if you're doing like an initial conversion from dentate to fixed. So this case here, typically what I'll do is I'll start off with a crestal incision along the center of the ridge, all the way around, and I'll just use my pencil as the scalpel basically so that we can kind of see the design of the incision. Typically I'll do a vertical release right at the center point of the ridge. The reason for that is because now when we are getting into digital, we're placing a special marker over here so that we can actually do digital scans. So we'll put our marker right at the midline, and then usually I'll put them right to the buckle of the incision point on both sides.
But you don't go over the ridge on the buckle with the posterior one, right?
The marker, placing the marker, I'll do out. I actually tilt them out so that my insertion point is basically when I drill, I'll actually drill. Let's see if I can move that a little bit. Sorry. So I'll actually drill distal.
Okay, cool.
And I'll put the marker, just go into the cortical plate on both sides. And then I'll put a marker in the center as well. So while I have my three, I'll put my 3 markers in this position, and we just have, I like to put 3 on the lower. There are some people that teach 2 in the retromolar pad area, but I found that the bite is much better once we place a marker right in the center point as well. So,
and then maybe you're going to talk about this tomorrow.
Sure.
Well, I think a huge key is the way you manage the soft tissue.
Yes.
And get it down, and your local anesthetic technique, and your.
That's a wonderful.
I mean.
Yeah.
That makes everything else smooth.
I'll show you the technique of how we elevate the flap tomorrow. That's a great idea using the anesthetic. Basically what I do is I do what's like almost like a hydraulic lift of the soft tissue. So I'll take a little bit of anesthetic. Usually I'll use 1 to 50 green Lido, and I'll inject it right at the point of the incision over here, and I'll actually inject as we go around. And what that'll do is it'll start the flap easily. Then I'll take a little 2x2, and I'll actually use my finger to start the flap as I press, and I'll actually retract all of the tissue with a 2x2. I'll put some real firm pressure, and I'll actually, in the surgery, I'll be using 2 thumbs, and I'll push down. And what that does, it'll loosen the hemidesmosome attachment that we have from the tissue to the bone, and it'll allow us to create a really, really nice flap. And basically then I can start using my periosteal elevator to go ahead and flap. When we're flapping, one of the areas, and we'll show this tomorrow, that we want to uncover is your mental foramen area. So you want to actually visualize your positions of your nerves. So this is very important because we will actually plan our positioning of our implant based on this. Our elevators that we use, the Molt, actually has a distance of 7 millimeters. Okay, so this is 7 millimeters wide. That's important because what we're trying to do is visualize from the mental foramen the anterior loop of the nerve. So when we do this, we'll actually place this right over the mental foramen, and then what we'll do is I'll have the assistant mark it with the pencil so that we know what our clearance is. So let's see if I can do this actually by myself. It'll be fun. So we have our distance from our mental foramen with the anterior loop. So that way we know this nerve can potentially be 5 millimeters. We give an extra 2 millimeters. That's why we're doing 7 millimeters distance. We give an extra 2 millimeters of room so that we know that we're not going to be drilling into that anterior loop of the nerve. Same thing over here. We'll mark both sides. Looks like G already drew the nice thing here. It helps with us with that. I will use a pencil, just a sterile pencil. I'll use a sterile pencil that will mark actually on the bone. So that loop is over here. So we'll actually, in surgery, we'll actually mark those spots. So you'll have an idea of where you should be drilling to.
That's awesome.
So the nice thing is we have kind of like a visual of where the end point should be, which our end point for our implant should be in this region over here, and then this region over here. So now from a starting point of the tilted implant, well, usually I like to start right just distal to the mental foramen. So I'll actually mark over here where our mental foramen is, and I'll mark over here where our mental foramen is. So just distal will be my entry point, and just mesial to that mental foramen. It does help actually to mark this on the patient. So I will draw those areas on the patient. Anteriorly, we want to place our positions usually in the intersection point between where the lateral and the central will be. So our anterior implants from an ideal perspective should be in these regions here. So what we'll do is we'll do our osteotomies here. This first burr that we have that is in our surgical kit, I have it loaded, is the Lance drill. And this Lance drill is what I'll start all of our osteotomies with. We run our burr at 1200 RPMs to start our osteotomies. And what I have is I have my starting point and I have my ending point. So I'll lay the drill right over that position. And
so you're going to be parallel to the lateral cortex then?
Yes, we're trying to run our osteotomy, and let me actually tilt this up. I'm using actually my lingual plate as a guide, so that way I know exactly what direction I'm placing my implant. So this is very important that, you know, from a standpoint of where we're gonna try and do. I will sometimes exit the cortex as well, so that I can get some kind of cortical fixation on these distal implants. So running slightly lingual to the center of the ridge and exiting into that position, pumping the drill as we go. And then we're gonna plan to put an 18mm implant in this site. I think we have 4.0 by 18 in our kit. So work on trying to get those 4.0 by 18 implants into this site. This is 15mm at the tip here. So we have actually another kit here. That is the long kit, and I'll actually show you guys. SIN comes with a long kit, and the markings on your long drills. The first marking on the long drill is 18mm. So since we're planning to put an 18mm, we'll actually over drill. We'll go to the second marking, which is a 20. So after I start my osteotomy with my short lance drill, I'll move over to this lance drill. And we'll go down. Now we're at 18. We're gonna go to the 20 mark. So now we're in 20. So we're basically prepping a little bit more than the length of the drill. And you can see right where we're coming out over here. And this is something that I like to do a lot of the time on these cases, is I like to go and create that little bit of cortical engagement on those distal implants. So this has changed from when we first started. When we first started, we were just kind of placing these in the center of the ridge, trying to get them in the center. More and more and more now, I like that cortical engagement over there, just so that I can have that. We'll enlarge here. And the new drill kit that's coming out from SIN will go and will tell you exactly where to stop for the type of bone. So like if we're placing a 4.0 implant, there's a 4.0 drill. With these models, when you guys are drilling on them, best thing to do is actually drill, because if we're gonna place a 4.0, usually I'll go to like in the mouth, I'll undersize it to a 3.6. In this case, I would probably go up to a 3.8 because these models are pretty rigid bone. So less under prepping on these guys than you would in the cadaver tomorrow. And when we're doing the cadaver work tomorrow, you'll get a feel for that bone. It'll be a little softer than these models. In the mouth, the live patient, you'll find that the bone is a little bit stronger than the cadavers as well.
Are you most often going to perforate on most patients?
Yes, if I want cortical engagement,
Okay.
which is 99% of the time.
Right.
So I want it to come out right out of that position. So
That strengthens it, like coming out through the cortical bone again. That gives it that added strength.
yes, you'll notice that once it engages the cortical bone, you'll feel the
It'll lock in.
yeah, and that is actually different than what we used to do in the past. We wanted it right in the center of that spongy bone. If you have,
It makes total sense. It's just
yeah,
kind of goes against what I've been taught, but it makes
Sure.
total sense. You know what I mean?
yeah, we've learned over the years that from the positioning of those implants, I want to have something that is, for these advanced cases, advanced atrofic cases that we're experiencing now, we want to have some kind of cortical plate engagement. So that's why we will.
You know, for like a single implant, it would be different.
Yes,
We're not
yeah.
worried about primary stability and getting that torque. Like
Right.
Yeah.
And then
Right.
again, for full arches.
Right.
Thank you.
Those two
Well, thank you, man.
implants are
Appreciate
balancing
it.
their whole posterior load. Yeah, absolutely. That's what I've been wanting to learn. Is just like, how the hell does that work? And now, you know, that makes sense. You're in all the strength you can give it. You never have soft tissue problems at the bottom where the.
We'll put a little graft material over there and then a little collagen membrane over the outside. No problem. We just use collar tape.
All right.
So. And we do very well with those. So positioning wise, we want to place the platform of the implant, so you can see right where that's exiting right now. Positioning wise, we want to place the platform of the implant about 2 millimeters subcrustal. When we do this, the other thing is we have in the kit positioners that will indicate the exit point of your multi-unit. So this will show you where your multi-unit is exiting. So you can kind of get a feel for your position of your multi-unit as well. So ultimately we want these to be as parallel as possible, where this yellow one is a 30. This has a 45 as well. There's a 45.
So these are the prosthetic kit?
These are in the long kit, the EpiCut long kit as well. Yeah. So the nice thing about these is you can actually see which
Which one you need to use?
which one you need to use, and then there's a 17. The blue is the 17. So you can kind of see that. But also the rotational aspect of the implant will help as well, because you can actually find out from a positioning point where that Morse connection is indexed to. So like that, you know, obviously you're going to rotate your implant a little bit more. So that's our position of our distal implant. So this is a relatively atrophic mandible, which is why we would elect to go with this positioning of the implant. Oftentimes I will go, if there is room, I will place an implant distally to this as well. So this is like a second premolar region. This is going to be more of a first molar region in this area. So we can go and prep for an implant in that site as well. And then prep for our anterior region. So if we do have room to place like an implant, let's say like this is probably going to be like a 10 millimeter implant here. So if we do have the room to prep for the 10 millimeter implant, I would make sure that you have about 11.5 millimeters of bone. Let's say if you're looking on your CBCT and you only have about, let's say you have about 10 millimeters of native bone, then I'd plan to place an 8 millimeter implant in that site. So for this particular case, let's say we have an 11.5 millimeter. Our markings, the 11.5 millimeter marking is the first line of the big silver area. So we'll go and drill down into that area here. And as we're doing this clinically, I'll typically tilt this a little lingually as well. So I've prepped to 11.5 to place a 10 millimeter implant. So I'm slightly lengthening our osteotomy and slightly under prepping our osteotomy.
So you're gonna hug the lingual crest with this too.
Correct. From a positioning standpoint, I'm looking at the lingual crest because there is an undercut a little bit on these models as well. So you don't want to be actually into the submandibular gland area. This is where there's a vessel there. So from a landmark perspective, we're gonna kind of like hug that crest. And clinically, I actually place my finger there as I'm doing the osteotomy so I can actually feel. Same thing, we'll prep here to our 3.8. Actually, you could probably, these models, you could probably prep to 3.3, I would say, to place a 4 millimeter implant. You can always enlarge it afterwards. So I've now prepped to 3.3. I'm gonna place a 4.0 by 10 millimeter implant. And I'll take a minute here also to outline how these implants come in their kit or inside of their packaging. So I'll grab a 4.5 by 10 here. 5.0 by 11 and a 4.0 by 10. That's a 5.0, 4.5. There we go. And usually in the standard ones, they're marked on the top of the vial. But here we can see basically they come in the vial like that. There's a transfer, implant transfer. That implant transfer goes right here, plugs right into your implant just like that. Typically I'm placing 4.5 by 10s in the molar position.
I like that they're blue, that's pretty cool.
Yeah, that's sweet. So that's worked out already. So we probably on these models need to prep a little bit more.
A little bigger.
Yeah. And if that happens clinically, I'll just reverse it out. And, you know, I'll say, okay, let's go ahead and do a, you know, another osteotomy there so that we can not overstress the bone. It is very common when I'm doing these cases that what I'll do is I'll insert and condense the bone. This implant, because of the taper, that hybrid taper that has at the tip, it's designed to be cycled. So you can go, you can tighten and then loosen. So the way I do that is I'll typically go, you know, 2 and then back up 1. And then back up. So I'm basically turning this little knob at the end of the wrench that helps with the different directions. And you can get really nice primary stability with this fashion.
Now, do you have a torque number you're looking for?
Well, clinically, we see about 60 in most of our cases for each one. So for each implant we're typically seeing about 60. And actually, that is one of the things I was not used to when I switched from Nobel to this because Nobel, the active implant, I wasn't getting as high of a torque.
Exactly.
So,
You know, I had some of those
yeah,
where you drive it down and then you can't back it out.
Right.
yeah,
Right.
Yeah.
Right. You send her trying to back it out. The patient's going, what's going on?
that's why we love our anesthesia. They're out.
Yeah.
They're out.
IV sedation's better.
So nice. At the beginning here, though, we were doing everything mild sedation, pretty
Yeah.
much every case.
Yeah.
So the nice thing is you can actually start with those cases with some mild conscious sedation, and then, you know, doing those easy cases like these edentulous cases are real nice. So as we're getting close to the end of the implant positions, you'll start to feel it torque up really nice, and you can see how our torque is with this. The last like 2 millimeters is where you'll hit your 60 usually. The reason for that is because usually when you're doing that and engaging cortical plates on the maxilla, same thing on the mandible with these tilted implants that we do. And the design of the implant makes it so that it torques down towards the end of the osteotomy. The way the implant's designed, the tip on all of the implants, all 4 sizes, 3.5, 3.8, 4.0, and actually the 5.0, so 5 size, or no, the 4.5. 5 sizes that they have are 2.35 millimeter tips. So the nice thing is that there's a 2.35 millimeter drill in this kit. So ultimately, a lot of the times if you have soft bone cases, what I'll do is I'll drill down with that 2.35 burr to my full length. And then what I'll do is I'll just crestally prep so that I can get the head of the implant in place for like a 4.5, I'll crestally prep, and then we can actually enlarge that bone and get really good primary stability with this. That's a technique that I like to use quite a bit actually. So you'll see that 2.35 millimeter drill in your kit. I mean, we've got super torque on this guy.
See, that's a tight implant. Definitely not a spinner.
So that's one of the things that you'll see. Now, I typically would probably sink that subcrestal a little bit more here. When we put our video together for this, we'll probably like cut it, like edit it a little bit. So we'll have one of the nice things about this implant, I do like significantly more than some of the other systems out there, is that it has what's called a double thread pattern. And basically what that is for every turn that you do with the implant advances a lot faster than it would than like a traditional single thread pattern. So the nice thing is as you're seating these, they'll actually seat a lot quicker clinically than like a traditional implant system, like a Biomet or like a BioHorizons or even like a Neodent. So.
Yeah, on the collar, we've got like some micro threads up on the collar that are like up here.
Yeah, well, you're very small. You're allowed to heat it compared to the tip. These wide ones are, and the
No,
tip-
they're the same.
Oh, it's the same. Well, it's a pretty wide pitch. That's good.
Yep,
That's why it runs fast.
yep, and it's double threaded.
So again, we want to place this slightly subcrustal. About 1.5 millimeters subcrustal is where we're aiming for.
I get impatient.
It's a lot of work.
It's time back and forth.
Yeah.
Different implant system, I have to get used to the feel of it.
At first, and then also these models are a little different than the mouth.
Yeah.
So like you'll notice that when you're placing them in the mouth, they see it a little bit faster.
Right.
But I tend to under prep these models a little bit more.
Yeah.
Just because I want to get some good stability, show you guys some good torque here. So now we've got that, we're going to go ahead and prep our anterior site. Typically on the lower, I do like to prep my my tilted positions first. That tells me whether or not I'm going to place a molar position here. So if my tilted position, I go and place my implant and I torque out really, really nice there, and I get a good AP spread, a lot of the times we don't need to place a distal implant here. But many times if I'm torquing and I get like maybe like a 35 here, then I'm gonna say, okay, I want a distal abutment. We'll place another implant in the distal ear. The next part, these anterior regions, when we're placing implants in this area here, the thing we have to be very, very careful of is the submandibular space over here. We don't want to impinge on that because there are vessels in that area, and we don't want to go through the lingual plate of the mandible here. So what we'll do typically is we're riding the buccal plate here. That's a little too far buccal, but I'm not usually engaging the cortex in these cases.
Going down the middle?
Yeah, just going straight down the middle. Because these anterior regions, we've got two of them in the anterior region, and usually the bone is really, really firm in this area.
Yeah.
So we don't have to worry about soft bone typically. The other part of it is the orientation of these. I typically will actually like to have a straight multi-unit on the lower anteriors. I try and angle that implant so that I can use a straight multi-unit on the lower anteriors. The reason for that is the patient phonetics. So on the uppers, I'll use like a 17, but on the lowers, I try and get a straight. So I just prepped to the 2.7 burr. I'm gonna plan to put a 3.5 in this region. We have in our kit here, we have some 3.5 by 13 millimeter implants. So I'm gonna prep to 15, and then we'll place the 13.
So Dr. Mike, you said you try to use a straight multi-unit for patient aesthetics or phonetics?
Phonetics.
Phonetics. Okay.
Yes, the reason why is because this area here in the anterior region is where your S and T sounds will happen with the patient. So upper and lower, okay, in those regions, I like to place my implants in positions that we don't have to impinge that screw channel or the thickness of the prosthetic more than what is natural for them. So what I'm thinking in my head is, where were this patient's teeth originally? What kind of reduction can we do to, if you're placing a multi-unit, you're typically adding about 5 millimeters of restorative space to that area. So for each one, that's including the screw as well, the seating of the screw. So you have to think where, if 5 millimeters north of this is where your thickness is gonna be. So let me place my implant there first. Usually I'll introduce my implant to the osteotomy with the motor.
You said we're gonna spend some time talking about reduction for like
Bone
when
reduction.
we're removing the teeth and we're dentulating, and then reducing the alveolus somewhat to get into solid bone.
That's important.
Right.
That's an important part. I have another model here that I'll show you.
I'd like to see. Do you guys have any videos on that?
We can make one
either
for you.
cadavers or live patients?
Yeah,
I would
sure.
love to see one with live patients. Or a cadaver would be great, but a live patient would be even better.
So that's our torque right there. We're torquing out like halfway into that. Torque is set at 35 here on the motor, and then what I'll do is I'll switch over to the wrench and we'll insert here. We'll back up. So now we've got our implants placed on this side here. I'm going to demonstrate how we place our multi-units. This area right here on the tilted implant, we do want to have a nice little channel in the area there so that we can actually place the multi-unit in place there. So I use this countersink as a bone profiler basically. I also use a little round burr as well, but this countersink is nicely shaped. So I'll run that usually around 800 and I'll just profile around this area here with the countersink. And what that does is it creates a little trough so that we can actually seat the multi-unit. Grab a 30 here.
You already measured the angle.
Yes, with our little profiler, our little angle measures right here. So if I look there, that's that. I'll put in an anterior one.
Line up as parallel as possible with those.
And then we've got another one here. So from this perspective, sorry, this one is not actually the right size. Let me grab I'm gonna grab this guy. So ideally, if we're looking at this, it's coming out of the center of the ridge. They're all generally nice and parallel. If I had to kind of change it, I would probably rotate this guy just a touch more. But how's that look on your guys? I can't see it.
Looks good.
Yeah,
Looks good.
looks parallel, so parallel.
Okay. So I'm gonna place my multi-units now. So we torque our multi-units to 25 on these immediates. I like to use my hand piece for that. We may have to profile a little bit more on this one to engage it. So I'm gonna go back to my profiling burr. I have a round burr. That's a really, really nice burr that I use as well for this part. That will flatten the ridge really nice. So it's a secondary alveoloplasty that we're doing.
So is that a safe tip burr?
It is, so the countersink burr is.
Okay.
So it does not cut at the end of it, which is nice. It does cut at this part as here though, laterally. So that's one of the things that it won't scratch the tip of the implant though. That's the nice thing about this burr. And I'll usually run it with irrigation so that the chips of the bone don't get stuck inside of the implant. And use my hand.
And the system we use in this section is just to don't have foam inside this.
Sure, yeah, they'll suction it out. And then we don't want to overheat anything too. There we are, we torqued in 25. Then I'm gonna do the anterior one, the straights. These straights come with a little carrier on them. That's the clear carrier. I'll hand tighten that first. And then afterwards, I'll show you the special tool that's designed to torque these down. So once you hand tighten them, you'll just rock that. It'll pull the carrier off. And then there's a special tool here. This is the multi-unit driver that will drive your straights. Okay. Okay.
So these go to 25 as well?
25 for all the multi-units is what I torque to. And then ideal torque for the implant would be 60. Would be great. This is what we try and aim to achieve for each case, is the 60 and 25. So that's the demo for that side there. So you can kind of see what we're looking at. AP spread, if we look at it from this angle here, really nice AP spread is what we're trying to achieve here. That's one of the keys in doing these in longevity. For longevity purposes, we talk about in the beginning of the course, having something that has a good AP spread that we can reduce the cantilevers on is going to create a better physics on the system, and you're going to maintain your implants super, super good. So what originally started when I showed you one of those all-on-4 tilted cases with the cantilevers. We did those for many years, highly successfully. What we've switched over to in the practice now is we are placing these distal implants whenever possible. So if we can place that distal implant, we're going to remove a moment of force, and we're going to have more stability. So we're placing those. So thought process, I'm always in a lateral position here for my anterior. I'm always in a premolar position, and I've always got a molar. This, the front of the molar. When I was learning, when they were teaching us, they were talking about never placing the implant in the molar position. More and more I find myself placing some there. Yeah. Just for a kind of,
That's a lot
to make sure.
of leverage back there.
Yeah.
When we using the bus and acrylic, man.
Yeah. It's different materials.
Yeah, when I saw the provisional prosthesis and start cracking, I say, I need to place implant here in the molar. And I go second surgery and place the implant. And I say, man, why I didn't?
While you have the patient in the chair. Yeah. It takes an extra couple of minutes just to place that one.
Yeah.
So it's a nice little thing. So
Makes sense. Yep.
Cool.
You see those X-rays, you're like, oh, that's a stretch back there.
So yeah, that's the other part of it, is that like if you're able to do it, you know, taking records wise, we're aiming for that. Like if I'm visualizing where I put it, it's usually in the mesial root of the first molar. That's where I like to put it. So.
And mechanics too, you're taking that stress off that.
The front
not that tilted implant.
Yeah.
So it's parallel implant, so it's, you know, it makes more sense.
You've got something there that's it's working towards something good there.